All right, today we're tackling one of the most high-stakes decisions you could make in acute care, how to tell the difference between a true mechanical bowel obstruction and its tricky mimic, pseudo-obstruction. Getting this wrong can have serious consequences, so let's get right into it and make sure we know how to nail the diagnosis every time.
Just a quick but important heads up before we dive in. This is for educational and reference purposes only. When you're in a clinical setting, you always follow your local guidelines and your hospital's protocols.
So picture this. Your patient presents with that classic triad, a bloated, distended abdomen, they're feeling nauseous, and they haven't had a bowel movement. The picture screams obstruction, but the million-dollar question is, what's the cause? Is there a real physical roadblock in there, or has the gut's engine simply failed? It's absolutely paramount to figure this out because the risk of a misdiagnosis is huge.
Here's how we're going to break it down. We'll start with the core differential, then dig into the causes. After that, we'll look at clinical clues and imaging, then we'll cover the very different ways to manage them, and we'll finish up with the most critical complications and key takeaways. So let's start with the big picture here. What we have are two fundamentally different problems that can look almost identical when a patient first presents. You've got one clinical presentation, but it can lead you down two completely separate paths with very different treatment plans. First up, we've got the real deal, mechanical bowel obstruction. It is exactly what it sounds like. There's a physical, structural block. Something is literally in the way, stopping everything from passing through. This can be a partial jam or a complete roadblock. And just remember, about 80% of these happen in the small bowel. And on the flip side, we have intestinal pseudo-obstruction. That word pseudo really says it all. It's a fake out. You get all the signs and symptoms of a blockage, but when you look inside, there's no physical lesion, no tumor, no twist. It's a functional problem. A failure of the gut's wiring, a severe neuromuscular dysfunction. You'll often hear the acute colonic version of this called Ogilvie's syndrome. Okay, now let's dig into the why behind all this. Understanding the root cause is really the first major step in sorting out your differential diagnosis. Are we dealing with a problem of structure or a problem of function? And when you look at the causes, the contrast is just stark. For a true mechanical obstruction, you're thinking structural issues. Post-op adhesions are the #1 bad guy for small bowel obstructions, followed by things like hernias and tumors. But for pseudo-obstruction, the triggers are totally different. We're talking severe illness, maybe a recent surgery, or the big one, medications, especially opioids and anticholinergics that just paralyze the gut. It's really a disease of autonomic dysfunction. So the big question is, how do we start to tease these apart at the bedside, even before we get a CT scan? Well, the history and your physical exam hold some really subtle but absolutely critical clues. It's all about reading the signs.
In a true mechanical obstruction, the pain is often front and center. It's usually that classic cramping, colicky pain that comes in waves as the bowel desperately tries to push against the blockage. Symptoms tend to come on fast, and when you put your stethoscope on the belly, you'll often hear those high-pitched, hyperactive, almost tinkling bowel sounds early on. If it's a complete obstruction, obstipation, the inability to pass any gas or stool, is the hallmark sign. Now, contrast that completely with pseudo-obstruction. Here, the massive abdominal distension is often the star of the show. Sometimes it seems way out of proportion to the pain the patient is describing. The onset is usually more gradual, and the bowel sounds, they're typically quiet, hypoactive, or even absent right from the get-go. It's a silent abdomen because, frankly, nothing is moving.
Okay, so your clinical exam is pointing you in one direction, but you need to be sure. This is where radiology becomes your best friend. It's what really solidifies the diagnosis, because you have to actually see what's going on inside.
The CT scan is really your workhorse here. It's the key. For a mechanical obstruction, it's going to show you dilated loops of bowel that suddenly stop at a clear transition point, with collapsed bowel right after it. It'll also help you find the cause, like a hernia. But in pseudo-obstruction, you see diffuse dilation everywhere, with no transition point. That's what rules out a physical block and helps you spot those scary complications like ischemia.
So, you've got your diagnosis. Now what? Well, this is where the road forks, and the two paths are dramatically different. Getting this next part right is everything. It determines whether your patient gets supportive care or an urgent trip to the OR. But first, some things are universal. No matter what the cause is, every single one of these patients needs immediate stabilization. That means nothing by mouth, NPO.
aggressive IV fluid resuscitation. You'll want to place an NG tube to decompress the stomach and keep a super close eye on their fluid balance. And of course, stop any drugs that could be making things worse, especially opioids.
Now, for a true mechanical obstruction, if it's just a partial block and the patient looks stable, you can sometimes manage with conservative care. But you have to watch them like a hawk for any signs of strangulation, things like fever, tachycardia, or worsening pain. If that obstruction is complete, or if there's any hint of complication, that is a surgical emergency. The goal is to get in there and relieve the block. The path for pseudo-obstruction is pretty much the opposite, with surgery being the absolute last resort. You start with conservative management for a couple of days, fluids, NG tube, and walking. If that doesn't work, you move up to medications. If that fails, you might try endoscopic decompression. Surgery is really only for when everything else has failed or if a complication develops.
When we talk about medical therapy for Ogilvie syndrome, there's one drug you really need to know, neostigmine. The standard dose is 2 milligrams, given IV, and given slowly. Now this stuff can be like magic, but it comes with a major warning, a significant risk of causing bradycardia. So any patient getting neostigmine needs to be on a cardiac monitor. This is not a drug you give and then walk away from.
All right, let's finish up by talking about the real dangers here, and then we'll boil this all down to the absolute essentials. What are the red flags that we simply cannot afford to miss?
Here is a number I want you to burn into your brain: 12 centimeters. If you see on an imaging report that the cecal diameter is greater than 12 centimeters, that is a massive warning sign. Because of the law of Laplace, the cecum, with its large diameter and thin wall, is the most likely part of the colon to perforate under pressure. A measurement this big means a perforation could be imminent, and you need to act fast. And the stakes are incredibly high. If a pseudo-obstruction goes south and leads to ischemia or perforation, the mortality rate can shoot up to 40%. 40%! That really underscores why getting this right, and getting it right quickly, is so critical. We aren't just treating some abdominal discomfort, we are actively trying to prevent an absolutely catastrophic outcome. So let's do a quick side-by-side to recap. True bowel obstruction, that's a physical block, often from adhesions with loud, hyperactive bowel sounds, a clear transition point on CT, and surgery is frequently the answer. Pseudo-obstruction, that's a motility failure, often from illness or drugs, with a quiet abdomen, diffuse dilation on CT, and you're going to treat it medically first.
Look, the key is just having a systematic approach. The next time you walk into a room and see that distended abdomen, just run through this framework. Is the pain colicky and intense, or is massive distension the main feature? Are the bowel sounds going crazy, or is the abdomen eerily silent? Answering those questions will point you down the right path. So, on your next shift, which subtle sign are you going to spot first?
Thank you for watching The Surgical Edge. Don't forget to like, subscribe, and share the channel. You can also support us by joining and suggesting surgical topics that you would like us to cover. For more insights and content, do subscribe to our podcast.